muscular dystrophy is a condition that affects children, and it's an inherited disorder. So it's caused by an abnormality in a gene called dystrophin. And this gene plays a very important role in maintaining the strength of our muscles. So it produces a protein called dystrophin. And if you have Duchenne muscular dystrophy, your body isn't able to produce this protein. So the effect of that is, as you get older from childhood, the muscles become damaged. And this process starts from birth, but it's not always apparent at birth. But it results in a gradual, progressive damage to the muscles. So early signs, I think, of the condition that would alert a health visitor or a nurse or a GP or a paediatrician would be a boy who is showing a delay in their motor milestones. That would be my first key sign. So a child who's delayed in walking. If it's a male child, for me that would immediately trigger a CK measurement. Again, boys with Duchenne can have global developmental delay. About a third of boys will be delayed in their speech development. And so actually I would say as well, any boy who's globally delayed, you might pick those patients up at a younger age. I would still trigger a CK measurement. As the child gets a little older, I think again, a boy who is having difficulty running, who's having difficulty jumping, not jumping at the normal age of 4, or a child who's struggling with PE at school, again, I would not hesitate to do a CK measurement. But sometimes boys with Duchenne can be a little underweight in their first year or two of life. So again, a boy who's failing to thrive, often you'll do a battery of tests, and if you get abnormal liver functions, so a raised liver enzyme, before referring that patient to a liver specialist, I would always do a CK measurement, because it could be that this child has Duchenne muscular dystrophy. Duchenne is a progressive disorder, and it progresses quite rapidly in children, particularly when they start to struggle with walking. It may seem that the condition is progressing quite fast. And then when the boys stop walking, anywhere between the age of 7 and 13, although with steroids we know that can be later, they may appear to go through a period of relative stability, but in fact actually the condition is still progressing. And what happens is they start to lose function in their arms, they start to lose strength in their trunk muscles, so sitting gets a little bit more tiring. And of course we know that with time they develop weakness in the breathing muscles, so eventually they will have hypoventilation at night time and need support with breathing at night time. We also know that the condition affects the heart muscles, and that leads to cardiomyopathy, and it becomes more obvious with time. Now this heart problem, it doesn't cause symptoms in boys with Duchenne. It causes symptoms only at a very late stage. So it's really important we monitor the heart on a regular basis so we can pick this up early and treat it early. And then actually as boys progress with the condition as they become adults, it can affect chewing, swallowing, it can affect the bowel. So it's really a multi-system condition. And what's really important in the management is to try and anticipate these problems. And so that needs regular, careful monitoring by a team, a big team of people. So the respiratory monitoring is measured with vital capacity at each visit. And then when the vital capacity falls below a certain level, then we would always do sleep studies, and we have the involvement of a respiratory physician. And for the heart, we would monitor the child with an ECG and a heart scan, an echo or MRI at each visit, at least on an annual basis. And again, if there's any change or any suggestion of any change in those results, we would treat with an ACE inhibitor or a beta blocker. And again, that needs a cardiologist to monitor the treatment. But also importantly, we know that we can keep children with Duchenne ambulant for longer with physical therapy. So the role of the physiotherapist is really important in terms of preventing joint contractures, showing the parents stretching, using splints at night time to stop the ankles from getting tight. And when the patient goes into a wheelchair, again, physiotherapy to stop those joints from contracting, and making sure that the seating is appropriate so we don't develop secondary contractures. When children become non-ambulant, we monitor the spine. That involves a spinal surgeon, and we might need to refer the patient for scoliosis surgery. So actually the care of the child and the adolescent with Duchenne is very complex, and it requires a very big, comprehensive, multidisciplinary team. And at each stage in the child's condition, that might involve different types of members of the team. So for example, in a young child, the physiotherapist may be perhaps the most important person and the coordinating physician to look for the complications of Duchenne. But then in a slightly older adolescent child, say around about the age of 11 or between 11 to 14, then we might want to involve an endocrinologist. If the child's non-ambulant, we may be involving a spinal surgeon, and also in our non-ambulant patients, the occupational therapist may become important as well. And then as patients get older, the importance of the respiratory physician, and throughout the lifetime of the child, the cardiologist as well. And then in the adult patients, actually we're finding gastroenterologists and speech and language therapists are very, very important key members of the team. And I haven't also mentioned, finally, as patients get older and they're wheelchair dependent, they may start to get pain. And particularly we see a lot of patients with pain in their hip joints and in their back, and that can be very severe. And we try and address that again with the occupational therapist and the physiotherapist to look at the seating to make sure the seating is appropriate. But if that still doesn't work, we need to involve our pain specialist as well. So the team gets even bigger as the patient gets older. And the pain specialist and a palliative care specialist can be very good for symptom relief. And finally, I haven't mentioned one of the most important members of that team is the psychologist. And because children and adults with Duchenne can have behavioural problems, the older patients suffer from anxiety and depression quite frequently, and younger children have a higher incidence of autistic spectrum disorder, but also of attention deficit disorder, so hyperactivity, challenging behaviour, difficulties with learning at school, needs very early diagnosis and early input from the education side of things. And I think the psychologist is also very important for the process of transitioning from paediatric to adult care, because that's a time of great anxiety for families and for the young person themselves. So it's a very big team that needs to be involved in it. I think it needs one central clinician to try and coordinate that care to make sure that it all happens at the right time and in the right place. It's really important we can identify this condition at a very early stage, so that the earlier we can pick it up, it means the earlier we can treat patients.